Good afternoon and welcome everybody. My name is Jeffrey Hotch. I am the Chief of the Division of Health Policy and Management and the Associate Director for the Center for Healthcare Policy and Research. We have with us today the Director of the Center, Dr. Courtney Lyles. She and I will be co-teaching this class. For some of you, this is a great opportunity to get CME credit, and you can see the code in the chat. For others of you, this is EPI 291. Welcome to EPI 291. Special shout out to the MPH students taking this class. We're really glad you're here. For some of you, you'll be watching this online. If you have any questions about the class, please contact Dr. Lyles or me. We'll be glad to try to help you. Today, it's our special privilege to welcome Professor Dan Tancredi. Professor Tancredi is a biostatistician at UC Davis with over 25 years of experience in statistical methodology. He has co-authored more than 300 peer-reviewed publications, tackling everything from clustered data to longitudinal models. Proof that not all heroes wear capes. Dr. Tancredi has contributed to many funded projects, including those that improve public health through rigorous data analysis. His work proves that while statisticians may not be flashy, their significance is always less than or equal to 5%. Dan, thank you so much for agreeing to talk with us today. The floor is yours.
Thank you for that fun introduction, Jeff. I'm going to talk to you guys about a paper that and a study that I'm very proud of that got published earlier this year in Lancet Child and Adolescent Health. It's on predicting pediatric pneumonia severity in the emergency room and some of the statistical considerations that went into that study. So the study was part of taking advantage of great research infrastructure that Dr. Nate Cooperman helped develop all around the world as part of the PERN network, the Pediatric Emergency Research Network. This is different than PCARN, which is another super important pediatric emergency room research collaborative that Nate helped develop. And I got involved in this study back in 2016. Todd and Nate led it, and our goal was to try to help inform emergency room doctors when patients, children come to them presenting with suspected community-acquired pneumonia. Help inform the doctors about which patients may end up having more severe course of illness. So we published the protocol paper in BMJ Open in 2020, and very proud to have published in 2025 the flagship for this study, which we call PERN pneumonia. And I was very pleased. The methodological collaborators were myself and Lillian, who's at Colorado. She's an epidemiologist. Most of the team are physicians here. Pneumonia is an acute infection where the tiny air sacs in the lungs fill with pus and fluid, and that makes it harder to breathe. So we've had a lot of progress, including some spectacularly successful vaccines, but it's still the leading cause of death for children, and most of those deaths are in lower income countries. In higher resource settings, such as what we studied in the PERN pneumonia study, it's still a very burdensome condition. It's a leading cause of very costly ED visits. A lot of antibiotics get used, and that has a lot of adverse consequences. And it also leads to costly hospitalizations. So it's helpful if we could have tools that we know reliably risk stratify the patients that come to us, so we have an idea of which patients are going to need more intensive help. So our primary objective is for kids in the age range of interest, which is 3 months through 13 years of age, develop a risk prediction model to discriminate mild community-acquired pneumonia from more severe, so moderate or severe community-acquired pneumonia. So the way we define this is mild is when it's community-acquired pneumonia that can be treated in the outpatient setting or with a very brief hospitalization that doesn't involve any additional oxygen or IV fluids. It doesn't require oxygen support. Moderate is if the hospitalization is less than 24 hours, but it did need fluids or oxygen, or if it's greater than 24 hours, but it doesn't involve the kind of escalation of care that we use for defining a severe outcome. So that was our primary objective, discriminating mild cases from the rest. But we also wanted to discriminate the kids are going to have the most severe illnesses. The planning for this study began in 2016. We began enrolling patients in February of 2019. Emergence of SARS-CoV-2 led to a rapid planning of an additional study that we call PERN-COVID. The Canadians were very astute in recognizing the need for a worldwide response to SARS-CoV-2. So they actually sent out a call for research very early in 2020. Remember, the escalation and shelter-in-place orders that happened in the United States happened in March, mid-March of 2020. So we actually had this grant from the Canadian government awarded in February of 2020. So they were very astute in recognizing the need for people to study PERN-COVID. So what actually happened was a little bit serendipitous. We were already in emergency departments all around the world enrolling patients that were presenting with suspected community-acquired pneumonia. So it only required a little bit of adaptation for us to set up a new study where we're now enrolling the patients presenting with suspected COVID-19. So that was a great thing, I mean, in terms of getting important research done. And we published a whole lot of important papers for the PERN-COVID study. That ended up being a little bit of a distraction, though, from the PERN pneumonia. That's why the study planning for PERN pneumonia began in 2016, but we didn't get the flagship paper out until 2025 because we were busy, as the rest of the world was, with with COVID. Dr. Stephen Friedman is excellent pediatric emergency medicine doctor in Alberta, and he led the PERN-COVID study. One of the things I wanted to talk to you guys about was how I did the power calculation for this study, because there's a little bit of potential room for research. So
Dan,
go ahead, Jeff.
can I interrupt for just a second?
Uh-huh.
Why do you have to do a power calculation?
We want to make sure that we're enrolling the right number of patients to be able to get an assessment, a definitive assessment for the our study objective. Like, we're trying to develop a reliable tool. We want to characterize how well it performs in discriminating between patients. And we want to be able to characterize that so we have sufficient confidence in it that we know that we made a difference. So if your sample size is too large, you're wasting resources trying to enroll patients when you could just go ahead and quit enrolling and start analyzing, getting results. If your study size is too small, you end up with results that are too inconclusive to inform all the objectives you'd like to be able to have definitively assessed. So for this power calculation, we were basing it on the idea that we'd like to develop a model that has really good ability to discriminate. And the way we're going to quantify ability to discriminate is with the area under the receiver operating characteristic curve. And this was for the secondary objective, actually, severe versus low moderate classification. In other words, we want to be able to see 3% of the patients have the severe courses of illness. We'd like to be able to come up with a prediction rule that allows us to discriminate them. If that prediction rule truly has performance of 0.725, we'd like to be able to establish that it beats a rule that only has a 0.6 area under the curve performance. The 0.6 might correspond to like a poor to fair rule, or it could even just be clinical judgment. But basically, we do want to assume that there might be a little bit worse ability to risk stratify the patients out there, but we need something that is stronger. So we powered it for 0.725 versus 0.6. So by the guidelines on the right-hand side of this slide, that would be like, we powered it for fair, sort of low end of fair, to beat a poor performer. And we were assuming 3% of the sample would have the outcome. So this is actually how you do the power calculation in SAS using the rock power macro. So you run the macro, you can find it online. These are the references for it. And it implements a couple of different ways for doing paired comparison of receiver operating characteristic curves. One of the most cited papers in the history of science is this paper by Hanley and McNeil for comparing the area under the receiver operating characteristic curve when you have the same cases have both algorithms being compared. SAS rock power can do that method, and it can also do another method that Nancy Obuchowski developed that's a little bit better suited for discriminators that are more ordinal, like more of a non-parametric kind of discrimination, instead of the Hanley and McNeil is based more on what's called a binormal or a fairly strong parametric approximation. So anyway, I'm assuming that it's 0.725. I want to compare it to a 0.60, and I have the null hypothesis at 0.60. I have to specify the correlation that I'm going to use. And you look at the Hanley and McNeil paper for a nice table that helps you figure out what correlation to specify there. And then I was assuming I had 2,500 patients, 3% of them have the outcome, two-sided test, alpha 0.05. I'm not using the Obuchowski adjustment, so I have ordinal equals 0 here. I equal 2 mean I do have two tests I'm comparing, and J equals 1. So it's saying if you do 2,500 patients, you're going to have power of 95.3%. So that's good power. Now, here's something that's a little bit controversial and would be a good topic for research. So in my mind, if you're doing a regression analysis, there's a big difference between when you have 10 degrees of freedom in the model and when you have 1 degree of freedom in the model. And if you do a sample size calculation for a multiple regression, you're going to get a much larger sample size requirement if you tell it that you're going to have 10 predictors in the model compared to 1. And that's as it should be. Because if you have 10 predictors in the model and all 10 of them are just bogus predictors that don't have anything to do with the outcome in truth, you have 10 different chances that a bogus predictor might end up looking good in a sample. So the hurdle you have to clear, the standard of evidence you have to clear when you have 10 degrees of freedom is higher. And you could actually figure out how much higher it would be. It's more or less about 88% higher. And that's easy to figure out because you can just go into G-Power or any other power and samples size calculator and go to the generic settings and play around with different settings for the number of degrees of freedom. And when you compare that to what happens when you do a multiple regression with different degrees of freedom, you see that you can see why you have the kind of inflation that you have. So even though no one else, as far as I know, when they're powering for a area under the receiver operating characteristic curve, I don't think I've ever seen anybody else say, hey, there's a difference between 10 degrees of freedom and 1 degree of freedom. You need to inflate the sample size when you actually do the calculation. I've never seen anybody actually do that. I have seen very smart statisticians who've written important papers on developing prognostic models talk about the effective degrees of freedom that come into a situation where you don't know what the predictors are that are going to go into the model. You have to search for them. And they have talked about the fact that the effective degrees of freedom is well over 1 in that case. But it seems to me that that should be taken to heart, and the power calculation should have an adjustment to reflect the fact that you don't actually have a rule that's already been developed. You are having to develop the rule. And you don't necessarily know how many degrees of freedom are in the rule that you're developing, but you know it's somewhere, it's probably less than the total number of candidate variables you're considering, but it's well above one. So what I did was say, you know what, if I were talking about 10 degree of freedom versus 1 degree of freedom, and I wanted 5% alpha and 80 and 95% power, I would need to inflate the sample size by 88%. So I did that for our initial proposal and say, you know what, we need to jack it up to 4,700. And I think this would be a great topic for research. I think a student, a graduate student or a postdoc could actually set up a simulation study, and I'm happy to work with them on that and kind of evaluate, should you or shouldn't you have this sort of sample size inflation to give you a more appropriate power calculation.
So Dan, can I just check
yes.
my understanding of what's going on? I think you're telling me if I have more variables on the right side of a regression, I might need more people, more sample size in my analysis. Is that the right way to think about it, or different?
And that's an absolutely unarguable point. If you're testing the null hypothesis that a regression model, a linear regression model, provides statistically significant explanatory power, and you only have one variable in that model, the burden of proof you have to cross is less than the burden of proof, the required test statistic or correlation you see when you have 10 variables in the model. And so a power calculation for a multiple regression automatically will ask you how many degrees of freedom are in the model and give you the appropriate sample size to account for the fact that the burden of proof that happens when you do the testing of the null hypothesis is going to be higher when you have 10 variables in the model than when you have one. So there's no controversy when it comes to multiple regression. Everybody doing a power calculation for multiple regression would know that there's a big difference in the required sample size when you have 10 degrees of freedom versus when you have one.
Dan, there's an excellent question. Thank you for your answer. That makes sense to me. There's an excellent question from Dr. Lyles in the chat.
Let me see if I can read it.
I can read
Does
it
the
too.
inflation of sample size for area under the curve apply when you're using machine learning AI for prediction? Is this common practice? It's absolutely not common practice, Courtney. This is why I think it would be a good research question. In my mind, there's a big difference between when you're validating a prediction rule that's already developed. So let's say a prediction rule like the one I'm going to show you guys later, it might have about 8 variables in it. Everybody knows what the 8 variables are, what the points that you put for each of those 8 variables are. You're just validating the rule. You're not developing it. So in that case, it should be the case that you should treat it as a 1 degree of freedom test, and you should just do a regular power calculation. When you don't know what the variables are, which is usually the case in AI and machine learning, in my mind, it's somewhere between 1 degree of freedom, as if you did know what the variables were, and however many variables that you are considering candidates. That clearly is too high. But it is true that in like a major guidance paper, which is this Frank Harrell paper from 1996, he talks about how the degrees of freedom is somewhere more, it's closer in spirit to the total number of candidates, the variables you considered for inclusion, than it is the total number of variables that ultimately made it into the model. And even if you did the total number of variables that ultimately made it into the model, that's still way more than 1. And that's really the right, if you're talking about linear regression, nobody is confused that you have 10 predictors, you didn't know what they were until you developed the model. You need to account for that when you're doing the testing. But I think there's just an oversight in practice that people haven't thought about it in the case of a logistic regression in an AROC. So my gut tells me we ought to be doing that same sort of adjustment, but people aren't doing it, but I think they ought to be. As far as I know, people don't do it, but old man Dan, who's about to turn 60 and just thinks of things in terms of like as a mathematical statistician, I don't see the argument that says that it's fair to treat a situation when you're trying to develop a model as the same as when you're trying to validate the model. To me, they're very different. And I know I would rather have more cases as somebody having to develop the model. But I also appreciate that my clients can't afford to be enrolling a lot of patients. But it is a question that should be, it's answerable mathematically. Like we could set up simulation studies where we have candidate variables that vary in how well they explain an outcome of interest. And we imagine that the investigator doesn't actually know which are the best variables to use and has to use a process to find them. And we could sort of set it up and do a simulation study and see what was the sample size that you wish you had to achieve the power you're trying to get. So I think it'd be a fun research study, but I don't know that, I don't think anybody's done it. And it is sort of an obvious question once, I think it's, do you guys feel like it's an obvious question now that I'm explaining it? Or do you feel like, what the hell is Dan talking about? I'm
I
hoping
think it's
people
an
think.
interesting question, Dan.
So,
Is
so
it similar in the way of thinking to if you're someone who subscribes to stepwise regression, backwards or forwards, and thinking about whether you
well,
have to?
the way that's the basic thing about stepwise or any other sort of procedure for trying to find variables is that um, you always have to be mindful of what the effective degrees of freedom should be for the test statistic. It's hard to hone in on exactly what it should be, but it's definitely the case that if you do a stepwise model and it ends up with 5 degrees of freedom as the number of variables in the model, you really are going to be foolish if you think that the relevant number of degrees of freedom for testing that model is really 5 degrees of freedom. It's definitely more than 5 because you consider more than 5 candidates.
So is that way of thinking kind of aligned with Courtney's question, aligned with your point that you kind of should be considering more degrees of freedom than you think you're considering when you're doing the power?
Yeah, and I don't know exactly how many more you should do. Like, I definitely considered more than 10 degrees of freedom worth of variables. I ended up with less than 10 degrees of freedom worth in the model. I don't know exactly what's the right inflation to use, but I do believe there should be some inflation when you're developing a model as opposed to when you're validating it. And that's absolutely unarguable when it comes to linear regression. No one thinks differently. It is the case that we don't necessarily know exactly how much effective degrees of freedom to use, but I think there is some guidance in the linear regression case on what's sort of a reasonable thing to do. If you use as the effective degrees of freedom the total number of candidates, that's going to be conservative. And that might be reasonable if you only have a small number of candidates. Like if the total number of candidates is only 30 degrees of freedom, it doesn't really necessarily hurt too much to pretend you have 30 degrees of freedom, even though you know you're going to use some sort of feature selection process to get rid of some of those 30 degrees of freedom. And that is more the setting we're in than in machine learning, because we are in a situation where most of the predictors, we're only considering predictors that my physician colleagues, and they're very sophisticated researchers, we're only considering the ones that they're going to want to consider. Like we didn't have to deal with a whole lot of different features, but most of us in other settings are dealing with like AI and feature selection in a context where we have way more features. And there's sort of two things to what I'm saying. I'm saying there's definitely more than 1 degree of freedom for sure. And so I'm pretty sure that there should be more than 1 degree of freedom. I'm not sure how many more. Like, how do we decide how many more? But I would definitely die on the hill that 1 degree of freedom is like wrong. I just don't know how much more. So I just use 10 in this case. But anyway, it's a potential question for research if anybody would like to get into it. I'm happy to kind of talk to you about how that might look and might even be able to participate in that study. Let's see. So, so if we had 3% of 4,700 kids had the outcome of interest, we need 141 kids with severe CAP. So, and if we had 141, that would put us in good shape for estimating sensitivity of the test, because sensitivity is restricted to the people that actually have the condition. And so part of the power calculation also sort of explained that, yeah, if we had 141 kids with severe CAP, our margin of error for our estimate of sensitivity would be tolerably small. So that's what we started off with. We were looking to get 4,700 kids. We talked to all the sites. We verified they thought they'd get 50 kids with CAP per year. So we were feeling pretty good. Like, yeah, we can do 4,700. It was sort of those situations where I was like, Dan, what do you want? And I was like, yeah, well, can we get 4,700? And they're like, yeah. And so I was like, oh, this is going to be sweet. Like, we're going to develop a model and we're going to for sure have a lot of patients. So anyway, what we ended up with was, oh, sorry. What ended up happening was, I can't see what the top number is on this graph because Zoom is making it hard for me to see, but we basically ended up with, as we were enrolling patients, because the COVID hiccup kind of threw things off, it became kind of important if we could justify curtailing enrollment, so we weren't trying to get to the 4,700. Fortunately, the proportion of kids that were having the severe classification, we were going to exceed the 147 we were pessimistically expecting with the 3% rate. It turned out there was way more than 3% of kids were having severe illness. And really, it's the number of cases that are driving the sample size. So we were able to make a protocol adjustment and target a smaller number of patients. So here's the statistical analysis plan. The protocol said we're going to do ordinal logistic regression because we have a 3-level outcome. You could be severe, you could be moderate, you could be mild. So we're going to do ordinal logistic regression, even though a lot of people don't even know what that is. Most people think logistic regression is binary. And you know, we're going to do this as long as we can verify the assumptions. And our goal is to get high discrimination capacity and fairly good calibration. The difference between discrimination and calibration, I'll kind of briefly touch on it. I talk about a little bit more at length in a commentary in JAMA that Kevin Fasella and I wrote in 2008. But it basically has to do with what the area under the curve statistic. One way to motivate it, heuristically, it has to do with if you formed all the possible pairs where you had one person that had the case and one person had the control. So each pair has one case and one control. And you looked at the predicted risk that the person would be a case. What's the probability that that predicted risk is in the correct direction? In other words, within that pair where one person's a case and one pair is a control, what's the chance that the predicted risk from your model is higher for the person that actually is a case than the person that's a control? So the area under the curve is actually equal to that. If it's 50%, that's a horrible test because it's just a 50-50 chance that the case is going to have the higher risk factor if the risk score is completely useless. If it's 100%, that's amazing. Like that means that every time you formed a pair with one case and one control, the case always had a worse predicted risk than the control. If we can get somewhere in between, that's where we like it. We can get to like 70%, 72%, 80%. So that's what discrimination is. If I take your risk scores and the risk scores that I'm talking about for purposes of calculating that area under the curve statistic, if I multiply them all by 5 times, they might no longer stay within the range of being probabilities, but it's not going to change the receiver operated characteristic curve. In other words, the receiver operating characteristic curve, which has to do with the relative ordering of the risk scores, it doesn't care what the risks themselves say for an individual person. All they care about is the chance that the case has a higher predicted risk than the control. So discrimination is a different issue from calibration. Calibration has to do with if we had 100 people that had predicted risk of having a severe outcome of 8%, is it the case that about 8% of those 100 actually have the severe outcome? So calibration has to do with how well does the predicted probability match up with the actual probability. Calibration is easy to fix. If you have good discrimination, you could fix calibration later on. But if you don't have good discrimination, you can't do anything about it except give up on that algorithm. So discrimination is way more important. Oh, thank you, Jeff, for citing the paper. It has a couple of paragraphs in there to talk about discrimination and calibration. Anyway, what we ended up doing was separate models for the two different dichotomizations. It turned out to be the case that some of the features that are good for one weren't as useful for the other. So what I mean is for discriminating moderate and severe versus mild, there were some variables that were useful there that weren't useful for discriminating severe from mild and moderate. We did use stepwise for feature selection, but in order to avoid the optimism bias that plagues stepwise regression, we did it in a bootstrap framework. So the way that worked is we bootstrapped samples. So bootstrapping means you're sampling with replacement from your larger data set to make a new data set. And then you do stepwise feature selection in that new data set, and you keep track of what variables got selected. And then you do another bootstrap data set, and you keep track of which features got selected when you did stepwise on that other data set. And you do like 100 different data sets that way, and you see which features got selected more than 50 times. And we use pretty stringent criteria for being entered into the model or being removed from the model. So we felt like this rule was pretty good at giving us screening features and coming up with ones that we trust or are reasonable. They have good face validity. And then in order to quantify the importance of the variables, we used Shapley values, which are kind of a fun thing. I will talk to you guys a little bit about what those are. And then in order to make the results useful for application, we converted the logistic regression coefficients into points so that the clinician in the ED can just see what signs and symptoms are available and just add up points, and then they can use the points to inform her or augment her judgment. So in the table, there's reports of the basic, the descriptives on the cohort, and give you a sense of some of the features that were available to us. About a fourth of the patients had antibiotics started before the ED visit. Fairly young patient population, in that the median was 3 years of age, and the interquartile range was before school. It was mostly preschool. So, and then features present, difficulty breathing, you could see by the relative frequency how it changes within across the columns, that probably is going to be a reasonably good discriminator, which makes sense because pneumonia is an interference in your ability to breathe. And then if your breathing rate or your heart rate is really high, that's also turns out to be a good discriminator, as does very low oxygen saturation. And so I'm going to scroll past this. And then this is the breakdown geographically of where we enrolled patients. A lot of them from North America, a lot from Australia and New Zealand, but also, pretty robust representation from Central and South America and from Europe. We didn't have as many patients from Asia. And then for a lot of the patients, there actually was imaging done. And so that's helpful in developing tools that can be based on imaging variables that might be available to the ED clinician within the first few hours after the child presents. So that was a separate analysis we call the imaging cohort. And here are the adjusted odds ratios we got for the two models, one for the full cohort. This is where we're discriminating moderate or severe from mild. So the two cohorts, one of them is all the kids, and the other one is the very large subset of kids that had x-rays done or imaging. So you can see if you have congestion or like a runny nose, we actually call that a -1 because that might be a situation where you're coming to the ED for some other condition, but it's not pneumonia. You have a sore tummy, you know, or you're not wanting to drink, or you've had antibiotics, those are each worth a point. If your heart rate or respiratory rate's above the 95th percentile for your age, that's worth a point. If we see chest retractions, that's kind of a bad sign. That's worth 3 points. If your oxygen sat is low, that's 3 points. And if it's really low, that's 6 points. And then on the x-ray, if we're seeing multilobar or unilateral findings of a certain sort, that also is worth a point. So the way this works is the clinician would just count up these different signs and get a point total. And the Shapley importance attached to these is kind of a helpful way to get an idea of what really mattered the most. So oxygen sats were like the most important. Chest retractions were like very important. The breathing rate percentile, they're above the 95th percentile, was also pretty severely important. And if you had a bad heart rate too, like if you were tachycardic, that would be indication also. And so let's talk a little bit about Shapley. Shapley is this very cool concept from Jeff's world. If you're trying to figure out the importance of a partner in a coalition, so think about like game theory or parliaments, either like forming coalitions of nations or forming coalitions of parties in a parliament, and you have these partnerships formed and you're trying to assess the relative importance of the different partners. Shapley proposed that one way you could do it is think of all the hypothetical ways the partnership could be ordered. So in the context of explaining variation in a model, if a variable is the very first variable added to a model, it's going to get credit for more of the explained variation than if that variable is added in as the 8th variable. Because if you add it in as the 8th variable, the other 7 variables at the picnic table are already gone over the barbecue pig. There's not as much left for the 8th person to get to explain. But whoever got to eat high on the hog, like whoever was there first gets credit for everything they can get credit for. So what Shapley proposed is, let's form hypothetical orderings of variables in terms of how much they explain variation. When you're going to use it for logistic regression, the way you tweak it is you use a pseudo R-square that's appropriate for a logistic regression. There's one that's very popular called the Nagelkirk pseudo R-square, so that's what I use. But then going back to Shapley's approach, we just form all the hypothetical orderings of variables, and we find out how much variable does how much credit does a particular variable get in terms of, like when that variable is added third to the party, what does it do when it's the third guest to show up at the party? What does that guest do when he's the first guest? What does he do when he's the 8th guest in terms of adding, enjoyment to the party? And so we're going to give that each of the variables their average contribution across hypothetical orderings of that variable's entry into the model. So it's a really cool way to divvy up credit when you have partnerships with multiple partners and you're trying to figure out a fair way to give them credit. So oxygen saturation is like super important. chest retractions, very important, high breath rate, high heart rate. The other ones aren't as important, but they still were important enough to survive the fairly rigorous standards for entry that we have. Any questions about the Shapley approach?
Yes, Dan, there is a question in the chat.
Okay.
I can ask Glorietta to read it if that would be helpful.
Let's see, there's a range within the categories, and what are the distinguishing features that would make? Yeah, that's a great question. So we operationalize that based on resource utilization. I described it in an earlier slide. We can go back to that. Let's see if I can find it. Yeah. So mild is more or less outpatient or a very brief hospitalization. Moderate is a brief hospitalization, but we didn't have to give you supplemental oxygen or fluids. Or it was a little bit longer hospitalization, but you didn't have one of the severe instrumentations that go into, you didn't have one of the more severe procedures. Like we didn't have to give you a mat, we didn't have to do like positive pressure ventilation. We didn't give you any vasopressors, or there wasn't chest drainage or any of these other kind of things. So that's sort of how we operationalize it. A lot of discussion among the clinicians went into that. And I just sat there and shook my head because I don't really know any of that. Thank you for that question, though. It's important. So here's what the raw curves look like when you either use the points, like the logistic regression coefficients, which is sort of impractical, or when you use the points. There's not much of a difference between them. So that's good news. And we were pleased that we had a really healthy area under the curve statistic. And it was really good in both cases. What the receiver operating characteristic curve is plotting is on the x-axis, it is plotting for a given proportion of false positives among your controls, what are you getting on the y-axis? And the y-axis is the proportion of cases you would be able to detect, like the sensitivity you'd be able to detect for that given proportion of false positives. So it's basically the true positive rate divided by the false positive rate. And so you could think about it as, you can make the point starting from the very far right. You could say, if we said everybody is a case, we'd have a false positive rate of 100% and we'd have a true positive rate of 100%. And then if we go to the next highest value from the second from the bottom score, and we say everybody that has this score or greater, we're going to say they are a case. Well, we're going to have less than 100% are going to be on the x-axis. And we're also going to have less than 100% on the y-axis. But we hope we go down further in the x-axis than we do on the y-axis. So that's basically how we plot the ROC. It's just saying for different hypothetical thresholds of your score, if you said everybody above that threshold, I want you to tell me what the x-axis value would be by looking at the proportion of controls that were above that threshold. And I want you to tell me what the ordinate, the y value would be by looking at the proportion of cases above that threshold. So a useless score would look like the 45-degree line or the identity line where y equals x. A score that has really good discrimination capacity would be well above that 45-degree line, and it would approach the left-hand border and the top border. Like it would get the west coast and the north border. And so the closer that the receiver operating characteristic curve gets to the upper left-hand corner, the one with x0 and y1, the better that curve is. And this is a really nice curve. 0.8 is great. We were very happy to get that higher number. Oh, we got questions in the chat. Let's see. Oh, okay. No questions.
Dan, we also have 13 minutes.
I know, I better be quick. And then here's a nice way to represent the data in terms of the points. So this is what's called a mosaic plot. So instead of just plotting a 2x2, like an R by C contingency table that has the cell counts, this is graphically showing you how many patients there are at different levels of the outcome. So severe is red, moderate is pink, and mild is whatever that is, like a lavender. And the height of the cell is proportional to the area of each cell is proportional to how many patients are in there. The height of the cell is the height and the width are set up so that the total area is proportional to the cell count. And then the overall width of the bars or the overall height is also captures the proportion that have that quantity. In other words, if you added up all the red and then compared that to the sum of all of the area for the moderate, you would be able to get the ratio of the severe to moderate. So this, if you started from the right-hand side of this figure to figure out what your X and Y points would be for the receiver operating characteristic curve, you can kind of see how we have a lot of pink and red on the right-hand side, and that's what's giving us the nice shape of the receiver operating characteristic curve, where it's far above the identity line. It's giving us that nice, healthy 80% value that we're seeing. So we thought this was cool. Any questions about this? And then, let's see. And then this is another table we provided that's useful for the clinicians that are familiar with likelihood ratios, positive and negative. You basically want the magnitude of these to be greater than 3 to be of like much use at all, or less than 0.33. What these do is help convert a prior odds that a patient has the condition of interest. You can multiply them by the relevant likelihood ratio to get a posterior odds. So if a kid were like 50-50, like you sort of were 50-50 about whether or not they had the condition of interest, and you got a likelihood ratio of positive score of 11.44 because the kid had a score of like 8. What we would do is take the odds of 1 to 1 and multiply them by 11.44. So we'd have odds of 11.44 to 1. And that would be like well over 90%. So it helps you get an understanding of how different point scores really strengthen your posterior probability judgment that the patient has that the patient's going to have a more severe course of illness. And this is sort of the rule, like posterior odds equal the prior odds times the likelihood ratio. So the likelihood ratio positive is the sensitivity divided by 1 minus specificity. And the likelihood ratio negative is 1 minus sensitivity divided by specificity. So if you have really high specificity, then if you get a positive test, that tends to rule in a patient. So there's a thing called spin and snout. So a highly specific test with the positive result gives you confidence that the patient probably has the condition. And a highly sensitive test with a negative result gives you confidence that the patient probably doesn't have the condition. So for the secondary outcomes, we ended up with different features, and we didn't end up with the same features as we needed for comparing mild and moderate versus severe. And the point totals were a little bit different also. So that's what this is showing. And the area under the curve statistic wasn't quite as good. It was pretty good though. It was still better than 0.725. So we were liking this one even also. And then a fun question is, how well did the new algorithm support what you would have gotten from physician judgments? Because physicians are pretty damn smart. So it turns out the physicians beat the points, but if you augment physician judgment, like you say, okay, physician, here's your judgment, but here, also use this algorithm. So we're going to take the physician estimated probability that the patient's going to have a bad outcome, and we're also going to use the points that from our algorithm as an additional predictor, and we're going to see how that joint approach does. That ends up having even better discrimination. and really excellent discrimination in that case. That supports the idea that the points could potentially augment physician judgment. So summary is there's a long road in order to develop an algorithm. I'm very proud of the work. It started back in 2016. A lot of really excellent physicians, excellent research infrastructure, and dedicated research assistants to acquire the data, and bless the patients for participating. We still need to validate the prediction rule, but it's a lot easier to validate once it's something you have in hand. And let's see, sorry. Having trouble using Zoom here. Sorry about that. Statistical input is needed throughout the life cycle of the project, and I'm glad to get to work with terrific colleagues like Dr. Cooperman, because I was available to him, when we were designing the project and all the way through from 2016. I think there's opportunities to improve the statistical methods, including in how we design how we power these studies. And so I gave you guys a research question I think would be worth investigation. And just want to note that the kind of progress we've made so far in improving care of little kids and just science in general requires a lot of cooperation, physician scientists, patient staff, governments around the world. And I thank you for your attention.
Dan, that's a wonderful introduction. Got us thinking. There's a question in the chat from Glorietta. Glorietta, are you okay going off mute and sharing your question with Dr. Tancredi?
Oh, I didn't see the question. Sorry. I know I see
Sure.
it.
Oh no, I was typing it. Don't worry, Dr. Tancredi. So my question was, because I always get excited when models fail to understand like why did it fail? Is there a pattern that you notice in some of the false positives? And the example I gave, which is a pretty simple example of like you had kids with really bad colds, they were marked as moderate, but ended up that they didn't go into pneumonia. Hoping that makes
that's a great
sense.
question. I think Gloria, so far, Glorietta, is it Glorietta, right?
Yep, Glorietta, mom and grandma are Glorias.
Yes, so Glorietta, that's a great question. We haven't dug into the moderates yet because the thing we are worried about are the severes, especially the severes you miss if you're using the rule that should be capturing all the moderates or severes. So, and for them, there were too few for us to really see a pattern. But it's potentially the case that we might be able to see a pattern to help us reduce the false. I think your concern was what the false positives. Let me make sure.
Yep.
Yeah, the false positives. So, yeah, I think that could be opportunities there. I'm thinking
Thank
of the
you so
difference between
much.
boosting and bagging. One of the kind of ways to think about how to improve a feature selection model is if you start with the one that's there and then look at the deviations, like what would be good things to add to improve things. So, but the strategy you're talking about is a very smart strategy. And here you're prioritizing the false positives, like you're treating it as and it is a concern, like when we think somebody's going to have a bad thing, and it might cause us to overreact. But when I was asking Nate and Todd and the other physicians the relative consequences of an incorrect decision, I think there was a little bit more worry about the false negatives, like the kind of situation you might send a kid home and you wish you hadn't. But both of them are important. Like and often the false positives, the stress that they create isn't properly appreciated. So in particular, like in breast cancer screening, there's a temptation by some naive people to say, well, it's okay if we alarm a person to make them think that they might need to get a confirmatory mammogram. And it turns out they really there was nothing going on. Like if you spread a whole lot of stress on a lot of people, that could be very burdensome on the society. So.
Dan, unfortunately, we have run out of time. Thank you so much for walking us through some of the considerations. Oftentimes, we don't get to hear the stories behind the scenes. Do you have any final thoughts for us, like 30 seconds or less? What's the sort of the main take-home message you want folks without a PhD in biostats to be thinking about based on your experience?
Well, I just appreciate the importance of cooperation. The UC Davis is a place where different disciplines do work together, and that we have colleagues like Nate and Courtney and you that help build teams across other institutions and stuff. We really, the way we make progress in improving the quality of all of our lives is by teaming up and addressing these things.
Well put, Dan, well put. Dr. Lyles, do you know of any sort of collaborative events that might be happening? I don't know, maybe end of the month-ish, perhaps a health policy flavor that we could share with the group right before we end today?
Yes, if you haven't seen it, thanks for the plug. The Science for Health Policy event's happening October 29th. And you can go to our website and find it. Yeah, oh, it's in the chat. Look at that. You can watch online. I think the in-person might already be full but we still have lots of ways for people to participate. And so more opportunities to come together, and I agree with Dan 100%. The collaboration's where it's at. So really appreciate you taking the time today, Dan.
Super. Thank you so much, Dr. Tancredi. Thank you, Dr. Lyles. Everyone, have a good rest of your week. Take care. Thanks for being here. We'll see you next Wednesday. Bye for now.